This is the digestion system embryology tutorial presented by SchrDbb with reference Langman Medical Embryology by T.W. Sadler. So here we're going to visualize the digestive system. So inside the digestive system, we're going to see we start here with this diagram, which shows still the longitudinal view of the embryo. So in the longitudinal view of the embryo, you see the ectoderm, you see the endoderm here, you see the androgenic cell cluster as you have seen in the cardiovascular system embryology. You see the cavities, amniotic cavity, you see the yolk sac as you have seen in the body cavities of the embryo. So this, you see that they are going to unfold as you have seen in the body cavity of the embryo to produce the different intra-embryonic cavities. So they unfold as such here, and then they are going to produce this, and these are going to be the different structures involved in the gut. And then you need to know that the gut is produced mainly from the endoderm, and then you have to know that the gut is going to be linked with the yolk sac by the vitelline duct. And then the gut is going to be divided into three main parts. You have the foregut, the midgut, and you have the hindgut. So those are the three main things you have to note. Now this diagram here is there to show you the regulation of development of the gut with certain genes. So these are the different genes involved in the regulation of the gut. So you try to look for it, but I'm not going to speak about it in further. So you can look up, can pause, and then you look for it. Now the next one here is the infolding in order to produce the gut. So you need to know that what. So as you have seen in the body cavity, we said that what we have inside the body cavities we have the endoderm, so you have at this level you have the ectoderm. Now between the ectoderm and the endoderm you have a mesoderm. So because the body of the human being is existing in trilaminar pattern, is it clear? So it means that you have three layers. You have the ectoderm, you have the mesoderm at the center, and then you have the endoderm in the inside. Now the endoderm, the part of the so at the level here, the endoderm is going to be having a lateral plate, has three main layers. You have a paraxial, an intermediate mesoderm, and then you have a lateral plate mesoderm. Now the lateral plate mesoderm is going to be divided into two. You have a splanchnic mesoderm, and then you have the parietal mesoderm, basically. So that parietal mesoderm now is what is going to be supplying the skin, while the splanchnic mesoderm is what is going to supply the viscera, from the lateral plate mesoderm. Now the paraxial mesoderm is what is going to produce the vertebral column and then the paraxial skeleton, while the intermediate mesoderm is what is going to be producing the musculature inside the viscera. Now we visualize this. So after this we have now this diagram. So this is the infolding. So you need to know that as this folds, so you're going to produce the ectoderm outside. So you're going to produce in order to encircle the body cavities of the embryo, because you need to know that at the beginning the embryo is not enclosed. The embryo is exposed to the amniotic cavity and is exposed to the yolk sac as if those latter structures were part of itself. Is it clear? So those structures are not intra-embryonic cavities, so they are extra-embryonic cavities. Is it clear? So A shows so the intra-embryonic, so that they are intra-embryonic cavities. So the amniotic cavity and the yolk sac are actually intra-embryonic cavity because they are in direct contact with the embryo, but they are not going to be the cavities inside the fetus in later stage of life. I hope you're understanding just that statement. The because if you see again our tutorials or initial tutorials on the general embryology, you see that there were extra embryonic cavities that were produced as from the chorionic villi. The chorionic villi are producing the extra embryonic cavities. Now we have the intra embryonic cavities which are in contact with the embryo, but not necessarily the body part of the embryo, because amniotic cavity is an intra-embryonic cavity, but it does not make part of the cavities inside the embryo. Is it clear? The cavities inside the embryo are the pleural cavity, the pericardial cavity, and the peritoneal cavities. Is it clear? But these are still the intraembryonic cavities and all that. So the next one, that is what you're going to visualize. The next is this. So in this now we have the bare area of the liver. So you have the bare area of the liver. You need to know that the dorsal aorta is going to be supplied at 3 main layers. So you are going to have the celiac artery, you have the superior mesenteric artery, and you have the inferior mesenteric artery. Those are the 3 main part of those aorta. Now the celiac artery is going to supply the foregut generally, superior mesenteric artery supply the midgut, and then inferior mesenteric artery supply generally the hindgut. Now this structure here is there to show you the different gut involved. So here you have the pharyngeal gut with the foregut, you have the tracheobronchial diverticulum at the level of the foregut, you have the esophagus at the level of the foregut, the stomach at the level of the foregut, the liver still coming at the level of the foregut, the pancreas at the full level of the foregut. Now the midgut starts from the second half of the second part of the duodenum now until the terminal, the distal 2/3 of the transverse colon. But at this level you don't have the transverse colon yet. So this is the cracker, and the cracker is going to produce both so this here is going to be the cracker. It's going to produce both the rectum, and it's also going to produce the urinary bladder. Is it clear? Those are 2 main elements, and so you're going to have the outflow of the cracker here, which is the proctodium. The proctodium now is the opening of the cracker opening. Is it clear? And in that cracker opening we have a small membrane. So this is gross pharyngeal patches. We have the esophagus with the long buds there, the liver growing and all that. Now this has also been shown in the respiratory tract tutorial, so esophageal, so embryology tutorial. This clinical correlation is tracheoesophageal fistula, which has been shown already in the respiratory system embryology tutorial. So now we need to know that in the growth of the stomach, you need to know that the stomach actually, like all the different gut structures, they're developing like a tube. So all those are tubes. So this is the longitudinal view. So we need to know that these tubes are going to rotate. So you see that they're going to rotate in this direction. So that is the direction in which the tube is going to rotate. You see the direction will rotate such that the one which was posterior goes to the left side, and the one which was anterior goes to the right side. Now you also need to know that initially the vagus nerve, which comes from the head and neck, is subdivided into 2. You have the right. So let's say that the embryo is facing me. This is going to be his right side, and this is going to be his left side. So here you need to know what comes from the head and neck part of the vagus nerve. You have the right and you have the left vagus nerve. Now the right vagus nerve is going to be on this side, and the left vagus nerve is going to be on this side. Now since there is rotation from the anterior goes to the right and the posterior goes to the left, that's why the left vagus nerve is going to be the vagus nerve is going to be on the and so it's going to be here and here. Is it clear? So the 2 vagus nerves, the one which was supposed to be at this side is now going to on the right, is now going to go posterior, while the one which is supposed to be at the left is now going to be go anterior. Now that's why the vagus nerve at the level of the respiratory tract is not going to be called the right and the left vagus nerve, but it's instead going to be called the anterior and the posterior vagal trunk. So the posterior vagal trunk is going to come from what? It's going to come from the right vagus nerve, the posterior vagal trunk, because it goes, what is on the right goes posterior, while the anterior vagal trunk comes from the left vagus nerve. Why? Because what comes from the left is what goes to the anterior comes from the left. Is it clear? So now when the stomach grows, it's going to produce now a lesser curvature on this side, and then a greater curvature on this other side. As it grows, the pylorus also grow. We have the anterior posterior axis, the lesser curvature increases, and all that produces to produce the immature lungs with a fundus, a body, a pylorus, the less and the greater curvature, and the cardia. So now this is still the orientation of the stomach. So at the beginning, the stomach is a tube, so it's connected with the dorsal mesogastrium. The dorsal mesogastrium is what is the mesentery that is going to connect to the stomach, and that mesentery is coming is because of the splanchnic mesoderm which attaches to the stomach. Because instead you need to know that what the layers of the gut has. The gut has 4 main layers. The first layer is the mucosa, second is the submucosa, third layer is the muscularis externa, and the fourth layer is the adventitia. Now the muscularis externa and the adventitia are coming from the mesoderm, and they are connected to the mesogastrium, to the dorsal, to the posterior part of the body. Is it clear? So they are connected to the mesogastrium, to the parietal peritoneum, so that it can adhere. Now when they say this orientation, you still have the left side is going to go posterior, while the right side goes anterior. So that's why it turns as such. Now when it turns like that, there is going to be a space between the liver, as you can see here. So at the beginning it's like that. Now you have it turns around, so there's going to produce now a space between the liver and then the stomach anteriorly. Is it clear? So that space is going to be called the omental bursa. So that space that is going to be between the liver and then the stomach is going to call the omental bursa, and is in that space you're going to have the lesser omentum. Is it clear? Because you need to know there are two main omental sacs. You have the lesser omental sac, or lesser omental space, and you have the greater omental space. The greater omental space is in front of the greater omentum. So we have the greater omental space is all in front of the greater omentum, while the lesser omental space is between the liver and then the stomach posteriorly, like that. Then they are having a connection between, so there's a connection between them, which is going to be the omental foramen between the two of them. So this is also another case where you visualize from posterior. At the beginning, the liver was anterior, as you can see here. This is the dorsal mesogastrium. The spleen is posterior to the stomach, and then these are the kidney. The kidney are retroperitoneal. So all this is intraperitoneal. What happens is that the stomach now goes and rotates and goes anteriorly, while the liver rotates to go posteriorly. Is it clear? So when the stomach goes anterior posterior, this is still the mesentery of the stomach, with the spleen lying here, and part of the pancreas now in the retroperitoneum, because the pancreas has different parts. The tail, the head of the pancreas is intraperitoneal, while the tail is retroperitoneal. Is it clear? Part of the pancreas goes retroperitoneum. So now this space now, which encloses the stomach, the liver, and then the mesentery of the stomach, is going to be is this part here, and this space is going to be called the lesser omental sac. Is it clear? So we have the lesser omental sac here. So this ligament here, which connects the pancreas and the spleen, is called the leonorenal ligament. So this is the pancreas, this is the gastroileal ligament. The gastrolineal ligament, though you can consider lineal as being the spleen. So the spleen can be considered as being the leonum. So this is leonorenal because consists of a mesentery ligament connecting the spleen and the kidney. Leonorenal ligament. The ligament connecting the spleen and the stomach is the gastrolineal ligament. This is the parietal peritoneum here. Now what connects the parietal peritoneum here like that is a falciform. So it's the falciform ligament connected to here in front. So it's what connects the falciform ligament, is what connects the liver to the peritoneum anteriorly. So these are how the structures are. You have the dorsal mesogastrum, you have the omental bursa, which is produced at the level of the between the stomach and the liver. You have the mesojejunum, you have the mesocolon here, you have the mesentery proper. The mesentery proper from the for the intestine. Now you have this is only when they are more mature. Now you need to know that what the omental bursa comes just inferior to the stomach, and so it can be a protrusion of so it's going to produce an omental sac with a lesser omental sac posteriorly. Now that omental bursa is a protrusion of the mesentery of the stomach downward. That protrusion of the mesentery of the stomach is going to go now downward, so to produce now the greater omentum from the greater curvature of the stomach for the greater omentum. Now these are the different structure how the omental sac is going to be produced. Now we see here that the stomach has the mesentery. Its mesentery initially is going to connect the spleen and the pancreas from the cross-sectional view. Now this is the longitudinal view. So this is the stomach here. There is the mesentery of the stomach coming downward here, and then the mesentery goes posterior to connect the spleen and the pancreas to the peritoneum of the posterior abdominal wall. Now you need to know that what in order to produce, you need to know the space now which was lying between the pancreas, the spleen, the stomach, and then the liver was called the omental sac, the omental bursa. Is it clear? So that omental bursa or the lesser omental sac, is it clear? Now we have now this omental bursa here is going to degenerate at this level. Is going to fuse together with the anterior portion of this one is the transverse colon. You're going to fuse with this anterior portion transverse colon now to produce now the greater omentum. So now you have now a space, two spaces. You have omental, the lesser omental bursa, and you have the greater omental bursa, which is going to be down here. Is it clear? So those are the two main spaces that is produced because of the mesentery of the stomach. Now this is still a diagram. This diagram of the embryo, this one shows approximately 25 days of gestation, and this one shows approximately 32 days of gestation. And you also visualize that they put 3 mm, 5 mm. Why? Because this is the crown to womb length. The crown to womb length can show you the precision of the gestational age based on the length from the head till the tail. So head to tail, the longest length from head to tail, that's the crown to womb length. Just clear, and that has been seen on the chapter of prenatal diagnosis. So if you want to visualize it, you can pause and then go and do a visualization of that before coming back. So now you have this other one here. You have this is the heart. We have seen about that in the chapter of cardiovascular system. So these are the respiratory diverticulum on the respiratory system tutorial. So this is the stomach coming to with the guts. Now you need to know that the liver is produced still from the endoderm, and then when the liver is produced, also going to bind with the mesenchyme, the mesoderm, the splanchnic mesoderm, and it's going to produce the different sinusoids of the liver. Is it clear? So this is the primary intestinal loop. The intestine, the small intestine, is going to be connected to the yolk sac via the vitelline duct, and then the bladder is going to be connected to seal the vitelline duct via the allantois. So at the beginning it's like that. The allantois is going to be at this terminal here, then it's going to be fused to be at the umbilical cord put together. Is it clear? So the next thing now to visualize is this. So this is the septum transversum that is going to be produced in order to separate the thoracic part of the body from the abdominal cavity. So this is the liver, the pancreas that is produced and all that. So this is approximately at the 6 days of gestation. Now here the liver has protruded more Basically, the pancreas protruded more, and then the mesentery of the gut has been produced more, and this mesentery are then linked. You also have the mesentery, which is going to link now the bladder, the rectum, also to the posterior abdominal wall. Now this is the anatomy now of the abdominal cavity, upper abdominal cavity. So you can see the liver here. Here, this is the omental foramen. Omental foramen is what, or the epiploic foramen, is going to connect the lesser omental sac to the greater omental sac. Is it clear? This is the costodiaphragmatic recess, which is going to be seen, which is seen here. The recess which is produced because of the costal surface of the parietal pleura and the diaphragmatic surface of the parietal pons. That space produced there is a costodiaphragmatic recess. Now this is a falciform ligament, which is the attachment of the liver anteriorly to the parietal pleura. This is the esophagus, the stomach, the diaphragm, the anastomosis between the right and the left omental arteries. So this is the right omental artery. The right omental artery is here. This is the left omental artery, anastomosis between both of them. So this is a transverse colon, and this here is the greater omentum, the gastrocolic portion, the greater omentum. Now the stomach abnormality, the main stomach abnormality that we're going to speak about is pyloric stenosis, which is circular constriction at the level of the pylorus. So here in pyloric stenosis, you have a patient who is suffering of hypersiluria, that is excessive salivation, and then the patient has also excessive vomiting. The vomiting is known bilus. Is it clear? So you have excessive vomiting. Excessive salivation is insane in case of tracheoesophageal fistula, but in pyloric stenosis they have projectile vomiting. So between 2 weeks to 8 weeks of gestation, of 2 weeks to 8 weeks after birth, and then those are the different abnormalities in pyloric stenosis. Is because of the constriction of the pyloric meatus. Now the next thing to visualize here that we're going to see is now the orientation. I've already said that the pancreas, so for this is the pancreas, I've already said that the stomach is going to rotate in this direction. It's similar with the duodenum and the pancreas. So the duodenum is rotate in this direction like that, such that the pancreas move here and this other side move here. Is it clear? So here you also have to know that what the part of the pancreas which is closest to the duodenum is called the part of the pancreas which is closest to the duodenum is going to be intraperitoneal. So while the part which is furthest away is going to be extraperitoneal. So you need to know those are the two main elements. Now in this diagram you have solid stage, you have recanalization. So this is the upper portion of the duodenum showing the solid stage and the recanalization. So at the beginning the duodenum was solid, and then later it has now fusion now with the common bile duct after recanalization. So recanalization stage is the fusion with the common bile duct, which is coming from the bile duct and then the pancreatic duct, basically. Now here you need to also know that the liver buds, this is the liver bud, this is the duodenum here. So the duodenum has a dorsal pancreatic bud, so you have a pancreatic bud here. So the bud of the pancreas, so it has there are two main buds of the pancreas in the embryologic origin. Is it clear? This is the stage of development of the pancreas. The pancreas develop with two buds. You have a dorsal pancreatic bud, which is going to be on the right side, and you also have, which is going to be on the left side, and also have a ventral pancreatic bud, which is on the right side with the gallbladder on the right side. Now what happens is that so the ventral, so at the beginning the gallbladder is going to produce its duct, which is called the cystic duct. The duct coming from the liver containing bile is called the common hepatic duct, which connects the right and the left hepatic duct coming from the two liver lobes. When it fuse now with the cystic duct, is going to produce the bile duct. Is it clear? And now when it fuses now with the liver, when it fuses with the pancreas, it produces the common bile duct. Now this is still the growth of the liver. So what happened is that still, like other structures, there is still going to be rotation, but now when there is rotation of the inside the with the pancreas, the rotation is such that the ventral pancreas rotates and then the dorsal pancreas does not. Is it clear? So what happened is that the ventral pancreas is going to rotate and come to this other side, while the dorsal pancreas did not rotate. So the ventral and the dorsal pancreas will fuse with each other. So we have the main pancreatic duct is going to be at the level of the dorsal pancreas, while the ventral pancreatic duct is going to be present here. So those are the two main pancreatic ducts. This is the uncinate process. So the uncinate process, so and the main pancreatic duct are the two main elements. So we have the main pancreatic duct, we have the uncinate process there. So those are the two. So they are going to fuse now with the bile duct now to produce that. So we need to know that what the main pancreatic duct at the beginning was not fused with the common bile duct, was only the ventral pancreatic duct that was fused, but later on they are going to fuse now with the common bile duct at the ampulla of Vater. So this ampulla of Vater here, so that you can move down. So the foregut is this structure. These now are the different elements that are involved with the production of the foregut. I'm not going to speak about that. Now the liver and the gallbladder abnormality. So the liver and gallbladder abnormality, you need to know that there are different abnormalities. So here you need to know this one is obliteration of the bile duct. Is it clear? So when you have obliteration, like this case, you have obliteration of the bile duct. So that is a problem. So in biliary atresia, obliteration of the bile duct, this is a great disorder because bile is not going to be secreted, and now all the function of the bile, like digestion of fats, like all the function of the bile are not going to take place in the body. Is it clear? So that's when you have obliteration of the bile duct. That's the first disorder. Second disorder, you have duplication of the gallbladder. Duplication of the gallbladder does occur because of embryologic origin of the gallbladder and all that. So you have also intrahepatic bile duct atresia. So and all that, or hypoplasia. Now the next clinical correlation is a clinical correlation for the pancreas. So for the clinical correlation of the pancreas, you can have, so you need to know that the ventral pancreas bud consists of two components, as I've already said. Occasionally, however, the right portion of the ventral bud migrate along the normal route, but the left migrate in the opposite route. So direction. So that's going to produce an annular pancreas. Normally, what happened is that the right is supposed to, the ventral portion of the pancreas is supposed to rotate to meet the dorsal portion of the pancreas. Is it clear? But now a problem is that if the dorsal portion migrate and the ventral portion migrate, they are going to produce an annular pancreas. An annular pancreas is one that is going to be enclosing the duodenum. Is it clear? So that's not normal. So it's going to produce an annular pancreas. So is it clear? So it's not normal. Now, accessory pancreatic tissue may be anywhere from the distal end of the esophagus to the tips. So we have also accessory pancreatic tissue from the distal end of the esophagus to the tips of the primary intestinal lobe. Now this is now the blood supply. We said the celiac artery supply the foregut. She supplied the foregut at the intraperitoneal foregut. So the superior mesenteric artery, the midgut, and then inferior mesenteric artery, the hindgut. So those are the structures. So the superior mesenteric artery, you can visualize where it supplies here. This is the supply here. This is the cephalic limb of the primary intestinal loop and all that you can visualize. Now you need to know that in the growth of the colon, you need to know that what we have, the sacral border is going to be produced, and the colon also rotates. Is it clear? Now, in the rotation of the colon, initially you need to know that the gut is a tube like that, and then connected to line duct to this portion. Now, we need to know that at the beginning, what happens is that what you're going to have a cecal at the caudal portion of the hind gut. You're going to have a cecal bud that is going to be produced, and that cecal bud is going to rotate such that the cecum goes to the left, the transverse colon which was down goes upward, while this other the most distal goes to the right. Is it clear? So that's the orientation of the colon. So what is going to happen is that initially it is like this. So you have the gut structures and then this. So what happened is that the cecal area which was down here, you have a cecal bud that's produced. The cecal bud is going to go on the left side. Then the intermediate area is going to go on the upper side, and then the most distal area is going to go to the right. Also, this cecal area is going to go on the right. The intermediate area is going to go on the middle portion, and then the most distal side is going to go on the left side. So as this. So at the beginning we have the cecal area here. We are going to have the intermediate portion as it goes right. So to the right it goes like that. So because of the lengthening of the colon and because of the lengthening of the ileum, we have orientation. So this in the ileum is the first one that grows. So we have the lengthening. It lengthens and takes its normal position. So it pushes the cecal bud upward. So when it pushes the cecal bud upward, later on you are going to have a shift of the cecal bud to the left side. Then at the intermediate region you're going to have the shift to the transverse colon. Then you have a shift to the sigmoid colon and all that. So have the different orientations. So as you can see in this diagram, again you're just seeing the cecal area is going to, because of the growth of the small intestine, you have the cecal bud push upward. Then later on, the cecal bud now is going to retract to be pushed on the left side. Now the next thing is at the level of the cecum, you have the different formation of structures. You're going to have the different tenure of the cecum, and then you have the different position of the appendix. Appendix can be located at different position. You have the 12 o'clock position, which is the subhepatic position. You have the 2 o'clock position, which is the pre-ileal and the post-ileal. You have the 4 o'clock position, which is the pelvic position. You have the 6 o'clock position, which is the subcecal position. And then you have the 9 o'clock position, which is the paracecal, the paracolic position. And then the last one now is the inside position, which is the retrocecal position. So those are the different positions of the appendix based on the embryologic development. Now this is a production of the greater omentum. The greater omentum is just an extension of the mesentery of the stomach. So you can see here, this is the mesentery of the duodenum that is fused with the abdominal wall posteriorly. So that's the dorsal mesenterium of the mesogastrium, and that mesentery also extends from the stomach upward to produce the greater omentum. And that is going to, when you cut that greater omentum, you see now how there is a mesocolon here, and you see the displacement, the proper orientation now of the colon. This is going to be the cecum, and this is the ascending colon, the transverse colon, descending colon, and the sigmoid colon, coming from the most distal aspect that was as oriented. Is it clear? Now, what are the abnormalities of the colon? So abnormalities of the colon, we can have mobile cecum. Mobile cecum is persistence of the portion of mesocolon give rise to mobile cecum. Now you need to know that what the mesocolon actually normally get fused with the posterior abdominal wall. Is it clear? But now, if the mesocolon do not get fused to the posterior abdominal wall, and if it does not degenerate, is to in order to enter into the posterior, in order to enter into the retroperitoneal cavity, it does not regenerate. It's going to produce a mobile secum. In most extreme form, the mesentery of the ascending colon fails to fuse with the body wall, such as long mesentery allow the abnormal formation of volvulus, and now that volvulus now result to what? And result to twisting of the intestine along its mesentery, because of this very long mesentery of the intestine. Now we also have a retrocolic hernia. A retrocolic hernia is entrapment of a portion of small intestine behind the mesocolon. So because the mesocolon if the mesocolon does not degenerate such that the colon should be on the retroperitoneal wall, you can have also a retrocolic hernia where the bowels can herniate through the mesocolon into the paracolic gutters. Now the next one, we have body wall defects. So we have already spoken about body wall defects. We have spoken about gastroschisis, and we said that gastroschisis when the anterior abdominal wall do not close the abdominal content. While in case of vitelline duct defect, so in case of omphalocele, we have protrusion of the intestinal content through the umbilical cord. Now for vitelline duct defect, if you have a persistence of vitelline duct in 2% of population, in a ratio of 2:1, more in males, in 2 inches away from the terminal ileum, from the ileocecal valve, all those are characteristic of Merkel diverticulum. So Merkel diverticulum is also called ileal diverticulum, and is one of the true diverticulum of the intestine. Why? Because it consists of all the stomach wall. So what happens is that this is a remnant of the vitelline duct. Normally the vitelline duct connects the umbilicus and then the intestine. So you can have the vitelline ligament, which is present between the umbilicus and the intestine. So these are the different forms of the Merkel diverticulum. One, you can have a Merkel diverticulum. So these are the vitelline duct abnormality. The first one is Merkel diverticulum, where you have a vitelline ligament which is going to connect the Merkel diverticulum, and then the second one is a vitelline cyst, where a cyst is going to be formed, and then it's going to be connected by 2 vitelline ligament, and then the last one is a vitelline fistula, which is going to communicate with the umbilicus. Is it clear? So when you eat food, some of the food is going to spill off through the umbilicus. So now the next one, after vitelline duct abnormalities, you can have abnormalities in primary intestinal route, in gut rotation. So when you have malrotation of the gut, intestinal loop may result to twisting of the bowels. So malrotation of the gut. You can have reverse rotation of intestinal loop occurring when the primary loop rotates 90 degrees clockwise. In this abnormality, the transverse column passes behind the duodenum. So here, these are some abnormalities of gut rotation. Is it clear? So normally this is how normally the gut loop is supposed to be, the transverse column is supposed to be anterior. The transverse column is supposed to be anterior to the duodenum. But when the transverse column get posterior to the duodenum, you have a reversed reverse rotation of intestinal loop because of 90 degrees clockwise rotation by the transverse column. Now we have also duplication of the intestinal loop and cyst. So in the duplication of intestinal loop and cyst may occur anywhere along the length of the gut. This is most frequently found in the region of the ileum. Is it clear? So A shows in diagram A you have abnormal rotation of the primary lobe. The colon is on the left side, abnormal rotation, all that. Now we also have the next abnormality is gut atresia and stenosis. So you can have stenosis and atresia of the different structures. So this you can see stenosis So you can see atresia here. You can see stenosis. So A is the most common form. You have primary stenosis and all that. So that's the first A structure. B now. So A is most commonly bowel atresia. So it's the most commonly occurring bowel atresia. So the most common this one occur in 50% of cases. C occur in 20% of cases, and D occur in 5% of cases, where some are it can extrude and pass through into the peritoneum. So those are the different things. So upper pilar atresia account for 10% of cases and all that. So this last diagram is the case of an upper pilar atresia which occur in the duodenum and account for 10% of bowel atresias. Is it clear? So the affected portion of the bowel is coiled around the remnant mesentery. So it's an atresia. So it's because of the affected portion is coiled around the mesentery. So it occurs in 10% of cases. But these are the other cases of atresia. So this one is the first, second, third, and fourth. So for upper pilar atresia is mostly because of the coiling of the mesentery onto a particular segment of the intestine. Now this is still the hindgut. You have seen the hindgut here. This is the urorectal septum. So this is the allantoid, this is the cracker membrane and all that. So this is the urogenital membrane. So you need to know that the cracker membrane is going to divide into two. It's going to produce the urogenital membrane, it's going to produce the anal membrane. Is it clear? With the anorectal canal and the perineal body from the urogenital membrane. Now, what are the hindgut abnormalities? So when there is a formation of that cracker and then the division to produce the urogenital sinus and then the anal sinus. So when it's divided like that, you can have different abnormalities such as rectovaginal fistula, where there is a connection between the rectum and the vagina. You can have a rectoanal fistula, where there is a connection. So rectoanal fistula and atresia, a connection between the rectum and the anus from another route than a normal route. Is it clear? So this is, you can have a rectoperitoneal fistula, so perineal fistula. You can have, so, and yet it's not connected with the anus, but it's connected with another part in the perineum. So this is the anal pit here, recto. This one is, again, you have this is a rectovaginal fistula. This is a urorectal fistula or ureteral fistula. This is the next one. We have this one is anal membrane rectal. So this is just a rectal atresia. So you can just also call it a imperfect, and also when you have rectal abnormalities and all that. So these are the different structures you can have. So from here you have visualized everything involved with the digestive system. I say thanks for your kind attention. Don't forget to like and subscribe for our channel. Thanks.